today we will be discussing one of the important topics of general pharmacology, which is bioavailability. So first and foremost, coming to the definition of bioavailability. So what is the definition? It can be said that bioavailability is the rate and extent. It is the rate and extent of absorption of a drug from a dosage form administered by any route. So what is bioavailability? It is the rate and extent of absorption of a drug from a dosage form administered by any route. Or in other words, we can also say that it is the amount or percentage of an active drug that is absorbed from a given dosage form following its non-vascular administration and it reaches the systemic circulation, or it is the percentage of the active drug which reaches the systemic circulation. तो बायोअवेलेबिलिटी क्या है? ये वो अमाउंट ऑफ द ड्रग है जो आपका सिस्टमिक सर्कुलेशन में पहुंच जाता है. सो वी विल राइट डाउन, इट इज अमाउंट ऑफ or the percentage of active drug that is absorbed from a given dosage form following its non-vascular administration and reaches the systemic circulation. ये डेफिनेशन थोड़ा बड़ा लगता होगा, लेकिन इसको समझने के बाद ये बहुत ही इजी डेफिनेशन हो सकता है. ओके, आपको बस इतना जानना है कि बायोअवेलेबिलिटी क्या है. वो अमाउंट है या परसेंटेज है किसका? वो एक्टिव ड्रग का है. और ये अमाउंट ऑफ परसेंटेज ऑफ द एक्टिव ड्रग जो कि पहुंचता है कहाँ पे? विच रीचेस द सिस्टमिक सर्कुलेशन. उसके बाद आप अपने आप ही ये डेफिनेशन जान सकते हैं कि अमाउंट और परसेंटेज ऑफ द एक्टिव ड्रग दैट इज एब्जॉर्ब फ्रॉम ए गिवन डोसेज फॉर्म फॉलोइंग इट्स नॉन वास्कुलर एडमिनिस्ट्रेशन एंड रीचेस द सिस्टमिक सर्कुलेशन. तो इसके बाद हम लोग जानेंगे कि कौन सी जगह पे बायोअवेलेबिलिटी 100% रहता है. तो बायोअवेलेबिलिटी क्या है? ये जो अमाउंट है जो सिस्टमिक सर्कुलेशन में पहुंच जाएगा. तो कौन सा डोसेज फॉर्म अगर रूट ऑफ एडमिनिस्ट्रेशन अगर हम देंगे तो बायोअवेलेबिलिटी 100% होगा. अगर हम ड्रग को IV देंगे, इफ ड्रग इज गिवन IV, then the bioavailability is 100%. Okay. अब हम चलते हैं कि कैसे हम कैलकुलेट करेंगे बायोअवेलेबिलिटी. हाउ टू calculate bioavailability. So to calculate the bioavailability, we have to plot a graph. And what is the graph? This is the concentration, or we can write it plasma concentration time graph. Okay, so we will take time in the x-axis and plasma concentration in the y-axis. Suppose a drug is given IV, then the concentration time graph will be like this. And suppose a drug is given orally, then the concentration time graph will be like this. So after that we'll find out the area under the curve of that given orally, and we will find out the area under the curve of that given IV. And then bioavailability will be equal to area under the curve after oral dose divided by area under the curve after IV dose into 100. This is the formula of bioavailability. Okay, so in short I can write AUC oral divided by AUC IV into 100. Further, I would like to add that this graph, the concentration time graph, gives an idea about the Tmax and Cmax. What is Tmax? Tmax is equal to time required to reach maximum concentration, and Cmax is maximum concentration reached. Is the maximum concentration reached. So from the concentration time graph, what are the things that we get? One is area under the curve, which gives the bioavailability. Second thing is Tmax we can get, and Cmax we can get. So these are the three things which we get from the concentration time graph. Now coming to two terms. One is pharmaceutically equivalent drugs and bioequivalent drugs. So what are pharmaceutically equivalent drugs? These are if they contain the same active ingredients, are identically in strength, concentration and dosage form. Same active ingredients and identical in strength, concentration and dosage form. And what are bioequivalent drugs? When the rate and extent of bioavailability of the active ingredients in the two formulation do not differ significantly. When rate and extent of bioavailability of two formulations do not differ significantly when tested by standard procedures. So these are the two terms. One is pharmaceutically equivalent, that is they have same active ingredients, they are identical in strength, concentration and dosage form. And the other is bioequivalent drugs. So what is bioequivalent drugs? When the rate and extent of bioavailability of two formulations, they do not differ significantly when tested by standard procedures. Now coming to the factors which affect the bioavailability. So factors affecting बायो अवेलेबिलिटी। तो ये क्या क्या हो सकते हैं? एक हो सकता है ड्रग रिलेटेड और दूसरा हो सकता है पेशेंट रिलेटेड। तो ड्रग रिलेटेड फैक्टर्स क्या क्या हो सकते हैं? एक है फिजिकल प्रॉपर्टीज ऑफ द ड्रग, दूसरा है आपका नेचर ऑफ द डोसेज फॉर्म। फिर पेशेंट रिलेटेड फैक्टर्स क्या क्या हो सकता है? उसके अंदर आ सकते हैं आपका फिजियोलॉजिकल फैक्टर्स, आपका फार्माकोजेनेटिक फैक्टर्स और डिजीज स्टेट्स। क्या क्या? फिजियोलॉजिकल फैक्टर्स, दूसरा है फार्माको जेनेटिक फैक्टर्स, तीसरा है डिजीज स्टेट्स। तो पहले हम बात करेंगे फिजिकल प्रॉपर्टीज ऑफ द ड्रग के बारे में। फिजिकल प्रॉपर्टीज, तो पहला आता है आपका फिजिकल स्टेट। तो फिजिकल स्टेट के अंदर हम मान के चलेंगे कि लिक्विड्स जो है वो बेटर अब्जॉर्ब होंगे सॉलिड से और क्रिस्टलॉइड्स ज़्यादा बेटर एब्जॉर्ब होंगे कोलॉइड से। लिक्विड्स बेटर एब्जॉर्ब देन सॉलिड्स एंड crystalloids better absorbed than colloids। दूसरा फैक्टर क्या है? लिपिड और वाटर solubility। तो एक सेल के सरफेस में हम जानते हैं कि सेल का जो मेम्ब्रेन है वो एक लिपिड बाइलेयर है। तो उस वजह से लिपिड सोल्यूबल ड्रग्स जो होते हैं वो पेनिट्रेट इनटू द सेल बहुत ही जल्दी करेंगे देन वाटर सोल्यूबल ड्रग्स। और एक एक्वस सॉल्यूशन में मिक्स होने के लिए वाटर सोल्यूबिलिटी वाले ड्रग जो है वो ज़्यादा रेडिली सोल्यूबल होंगे देन ऑयली सॉल्यूशन। तो एब्जॉर्प्शन साइट पे, so in the absorption site or at the absorption site, aqueous solution they mix more readily than oily solution. So what happens? They are absorbed faster. कहाँ पे? Where they are absorbed faster? At the absorption site. Aqueous solution they mix more readily than the oily solution. But at the cell surface, what happens? The lipid soluble drugs they penetrate into the cell faster. सेकंड हम आएंगे डोसेज फॉर्म पे। तो इसमें हम देखेंगे तीन चीज़ें। पहला चीज़ है पार्टिकल साइज। फर्स्ट थिंग इज योर particle size. Second thing we will see the disintegration and dissolution rate. And the third thing which we will see is the formulation. So coming to the particle size. If the particle size is less, then absorption is increased, and so bioavailability is also increased. Now the disintegration time. So what is this disintegration time? Disintegration time, it measures the rate of breakup of tablet or capsule into the drug granules. Rate of breakup of tablet into drug granules. And what is dissolution time? तो डिसइंटीग्रेट क्या होता है, एक बड़ा पार्टिकल छोटा 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 ग्रैन्यूल में कन्वर्ट हो जाता है. तो इट इज़ द रेट ऑफ द ब्रेकअप ऑफ द टैबलेट्स इनटू द ड्रग ग्रैन्यूल्स. एंड व्हाट इज डिसोल्यूशन रेट और डिसोल्यूशन टाइम? इट इज़ द rate at which the drug goes into the solution. Drug goes into solution. There is much of confusion between these two terms at this point of time. So I need to clear it that dissolution time or rate you can know by its wording itself. Its nomenclature says that dissolution. So we need to highlight this thing, solution. Okay, the rate at which the drug goes into the solution is called dissolution rate. And what is disintegration time? You might be knowing the literal meaning of the word disintegration. What is disintegration? It is the breakup of a larger thing into smaller things. So it is the rate of a breakup of the tablet into the drug granules. Okay, so clear about disintegration time and dissolution time. Next we'll go to the formulation. So coming to the formulation part, the inert diluents like the lactose, sucrose, starch are used in formulating powders. Or tablets. Now these, they may affect the absorption. And thus they determine the bioavailability. So these were the drug related factors. Now coming to the patient related factors. So in the patient related factors, first we'll see the physiological factors. So in the physiological factors, first is the pH of the GI fluid. Now acidic drug, they are absorbed in the stomach. Why? Because the pH is acidic. So these drugs, they remain unionized in acidic pH. Basic drugs are not absorbed till they reach the alkaline environment of the small intestine. So basic drugs, they are not absorbed till they reach the alkaline environment of small intestine. Okay, so basic drugs, they are absorbed in the small intestine, acidic drug in the stomach. So the action of the basic drugs is delayed when they are administered orally. Action of basic drug is delayed when it is administered orally. Okay. Another point we need to remember here is that at the pH values of intestine strongly acidic or strongly basic drugs, they remain highly ionized, so they are poorly absorbed. Okay, so pH value of the intestine, at the pH value of the intestine, the strongly acidic and strongly basic drugs, they are highly ionized, therefore they are poorly absorbed. And acidic drugs, they are absorbed in the stomach, and basic drugs, they are absorbed in the small intestine. So the action of the basic drug is delayed when we give the drug in the orally administered form. Now coming to the second point of the physiological factor, that is ionization. So in the ionization, the lining of the GIT is impermeable to weak organic acids and base. So the weakly acidic form, they exist, weakly acidic basic drugs, they exist in two forms. So one is unionized component, which are predominantly lipid soluble and are absorbed readily. The unionized fraction can cross the cell membrane, but the amount crossing over is determined by the gradient of concentration between the lumen and the portal venous blood. So the lining of GIT is impermeable to weak organic acids and bases. So weakly acidic or basic drugs exists in two forms. Okay, so what are the two forms? Unionized and ionized. This unionized form, it readily crosses the cell membrane. Okay, but this amount crossing over is determined by the gradient of concentration between the lumen of the gut and the portal venous blood. Okay, so this is all about ionization. Now coming to the GI transit time. Third is GI transit time. So what is this GI transit time? The amount of time required to transit from the GIT. So the presence of food and the volume, viscosity and tonicity of the gastric content, they influences the drug absorption by altering the GI emptying time. So the absorption is rapid if the drug is given in empty stomach. Absorption rapid if drug given in empty stomach. Increase peristaltic movement or activity in diarrhea. What it does? It reduces the absorption. Other factor is edema of the GI mucosa, that also impairs the absorption. Now there are certain examples of drugs whose absorption is more in presence of food. In presence of food. So these drugs example are, you remember by the mnemonic CCG, chloroquine, carbamazepine and G for griseofulvin. Okay, and drug whose absorption is hindered by the presence of food. Is hindered by the presence of food. These are ampicillin, aspirin, captopril. Okay. Now coming to the presence of other agents. There are certain agents which either increase or decrease the bioavailability or absorptions of the drugs. Like vitamin C enhances the absorption of iron. Vitamin C enhances absorption of iron. Okay, then in presence of liquid paraffin, the fat soluble vitamin, their absorption is reduced. Calcium present in the milk and antacids, they reduce the absorption of tetracyclines. So what are the examples which we discussed? One is vitamin C, which enhances the absorption of iron. Liquid paraffin, it decreases the absorption of fat soluble vitamins. And calcium present in the milk and antacids, they reduce the absorption of tetracyclines. Now another factor is enterohepatic cycling. Okay, this increases the bioavailability. So as the name is enterohepatic, okay, from the intestine to the liver and again from the liver to the intestine. This kind of cycle is called enterohepatic recycling. Okay, it takes place in some of the drugs. Okay, So this also increases the bioavailability. We will discuss enterohepatic cycling in another lecture. Now, area of the absorbing surface and local circulation. Area of absorbing surface and local circulation. So drugs, they are better absorbed in the small intestine than the stomach. Small intestine better absorbed than the stomach. Why? Because small intestine, as we all know, has got a larger surface area. And also another factor is that increased vascularity increases the absorption. Okay. Next, coming to the first pass metabolism. Okay, so what is the first pass metabolism? It is the metabolism of a drug during its passage from the site of absorption into systemic circulation. So it is the metabolism of the drug during its passage from the site of absorption into the systemic circulation. So where this metabolism is taking place? It is taking place either in the gut wall or in the liver. Okay, so all orally administered drugs are exposed to the metabolic enzymes either in the intestinal wall or in the liver. And also it can occur in a limited magnitude for transdermally administered drug in the skin. Transdermally administered drug in the skin, but this is of limited magnitude, or for any drug reaching venous blood initially in the lungs. Okay, but mainly it occurs in the first pass metabolism occurs in the gut wall or in the liver. So basing on this, we need to discuss whether these are fit for oral use or not fit for oral use. So drugs which have got a high first pass metabolism, they require either high oral dose or they are not given orally. So the drugs which have high first pass metabolism and are not given orally are not given orally due to high first pass metabolism are isoprenaline, lignocaine, testosterone, or they have got a high oral dose because of high first pass metabolism are propranolol, okay, morphine or pethidine, verapamil. So these are the drugs which have got a high oral dose because of high fast pass metabolism. The other factors are pharmacogenetic factors. These pharmacogenetic factors, they increase or decrease the absorption and the bioavailability and drug response. This we will be discussing as it separately, as because it is itself a short note. Other is disease states. So the absorption and first pass metabolism may be affected in conditions like malabsorption, thyrotoxicosis, achlorohydria, and ultimately these things will lead to changes in bioavailability of the drug. Okay, so this was all about bioavailability. So let's revise this once again. So we knew that what is bioavailability? It is the percentage of the active drug that is absorbed from the given dosage form following its non-vascular administration and the amount that reaches the systemic circulation. So it is the rate and extent of the absorption of the drug from the dosage form administered by any route. So in which kind of route of administration the drug is 100% bioavailable? It is IV route, intravenous route. Directly it is given into the systemic circulation. So the bioavailability is 100%. So how to calculate the bioavailability? So when you calculate the bioavailability, you will have to plot the concentration time graph, and in the concentration time graph you can get Cmax, that is maximum concentration reached, Tmax, that is the time required to reach the maximum concentration. And bioavailability, how you will calculate? You will calculate area under the curve after the oral dose divided by area under the curve after the IV dose into 100. So then we came into the concept of pharmaceutically equivalent and bioequivalent drugs. Next, coming to the factors affecting bioavailability. In this we saw there are certain drug related factors and patient related factors. In the drug related factors, we discussed the physical properties of the drugs, the nature of the dosage form, and then the patient related factors, in which we discussed the physiological factors, the pharmacogenetic factors, and the disease state. Now coming to the drug related factors. In the physical properties, we saw the physical state, the liquids have greater absorption than the solids, and crystalloids have greater absorption than the colloids, and the lipid water solubility. So in the absorption side, the aqueous solution, they mix more readily than the oily solution, so they are absorbed faster. But at the cell surface, the lipid soluble drugs, they penetrate into the cell faster. Coming to the dosage form. Now three things are important, that is particle size, the disintegration time and dissolution rate, and the formulation. We have discussed each of this. And then in the physiological factors, we discussed how the pH of the gastric fluid, the ionization of the drug, the GI transit time, the presence of other agents, and enterohepatic cycling and area of the absorbing surface, and the first pass metabolism, how they affect the bioavailability. Next, the pharmacogenetic factors, which we will be discussing separately because it is in itself a short note. Then the disease states like the malabsorption, thyrotoxicosis, achlorohydria, they causes changes in absorption, and thereby there is changes in the bioavailability of the drug. So this was all about bioavailability and factors affecting bioavailability. Thank you.